Namaste. Now I am going to talk about monkeypox pathogenesis, histopathology, diagnosis, and treatment. The pathogenesis and pathophysiology of monkeypox begins from the transmission of the virus, whether it may be human to human transmission or animal to human transmission. The most common cause of human to human transmission, as rare as it is considered, is respiratory droplets. Here in this chart you can see direct contact with contaminated objects or surface and direct contact with mucocutaneous lesions of the infected individual. Monkeypox virus follows a similar infectious pathway to smallpox, beginning with the exposure of the oropharyngeal or respiratory mucosa of the host. Following the viral entry, the monkeypox virus replicates at the site of inoculation. In human to human transmission, the site of inoculation is respiratory and oropharyngeal mucosa. Following viral replication in primary viremia, the viral load spreads to the local lymph nodes. In secondary viremia, the viral load will reach the distant lymph nodes and organs through circulation. The entire process represents the incubation period, typically lasting 7 to 14 days, with an upper limit of 21 days. Clinical manifestation of monkeypox is not visible during the incubation stage, and therefore the incubation period is not contagious. The symptoms and clinical manifestation of monkeypox can be correlated to the prodromal stage. During prodromal stage, the secondary viremia occurs from the lymphoid organs to the skin and tertiary organs such as the lungs, eyes, gastrointestinal tract, etc. It is during prodromal stage that an individual is deemed to be the most infectious. This is largely due to the presence of symptoms such as mucocutaneous lesions and lymphadenopathy, among other non-specific symptoms. The common non-specific symptoms begin to develop 1 to 2 weeks after an individual has been infected with the monkeypox virus. During the prodromal stage, the non-specific symptoms triggering the immune system emerge such as fever, lymphadenopathy, myalgias, etc. Due to the non-specific nature of the initial symptoms, an infected individual may attribute these symptoms to seasonal flu or the common cold. Initial activation of the immune system will always cause enlargement of lymph nodes, including maxillary, cervical, and inguinal, occurring in secondary with onset of fever. In case In cases prior to the 2022 outbreak, rashes would be observed appearing 1 to 3 days after the onset of fever and lymphadenopathy. In the emergence of the new mucus, in the emergence of new these cases, Harris states that for some patients, those prodromal symptoms might be mild or not even noticed at all, suggesting that some individual may not be aware of any symptom at all until the appearance of the rash. In the typical cases, the fever often declines on the day or up to 3 days after the onset of the rash. The rash will first appear on the face and will quickly appear in the centrifugal distribution across the body. The centrifugal distribution means that there will be more lesions on the extremities and the face rather than the abdomen and trunk. Lesions in the oral cavity cause difficulties with eating and drinking and thus hinder the nutritional intake of the infected individual. The skin lesions cause extensive protrusion of the skin and thus raises concern about the secondary bacterial infection of the skin, and this has been complication that has been noticed in 19% of unvaccinated monkeypox patients. The rashes observed in individual follows a very distinct presentation. The hallmark feature of monkeypox is disseminated vesiculopustular rash. The rash itself has been noted as going through several stages before they enter the desquamation phase, in which the scabs begin peeling off. It has been noted that these distinctive lesions often present first as anthema, macular papular, then vesicular and pustular. These lesions will ultimately become crusted within 2 or 3 weeks. Prior to the rash appearing on the skin, an individual will see lesions developing on the tongue and mouth. These lesions are called anathema. Once the crusted lesions peel off and reveal new skin underneath, an individual is no longer considered infectious. This is referred to as desquamation phase. In some cases, individual may be left with scabs. Once scabs peel off, some individuals may even present with regions of hyperpigmentation and hypopigmentation where the rash was more concentration. The lesions are painful in all stages until the desquamation phase, at which point the crusting causes individual extreme itchiness. Histopathologic analysis of the patient earliest stage of the lesion development in humans reveals epidermal necrosis at the center of the individual lesions concurrent with nascent extension into the superficial layers of the dermis. It is it has also been observed in monkeypox infected non-human primates that lesion pathology intensifies as pustules form, with progressive ulceration, necrosis, and interstitial hyperplasia. Furthermore, derm edema is prominent at the margins of necrotic areas, and clefts develop in these interstitial spaces between cells where the fluid and cellular debris accumulates. Eventually, inflammation and necrosis of the superficial dermis predominate, and destruction of the sebaceous glands and follicles is evident. Together, these attributes leads to the characterization of the affected areas as partial thickness wounds, and as an injury of the extent points to the need for active prevention of complications such as bacterial infections and possible cellulitis. Interventional studies demonstrate that the use of most occlusive therapies is successful, prompted re-epithelialization and healing at herpes lesion sites, and as such the cause of most occlusive dressing could be contemplated for patients with extensive facial coverage of rash lesions. Furthermore, gastrointestinal symptoms that arise by the second week of illness, such as vomiting and diarrhea, can contribute to severe dehydration in an infected individual. The mouth and throat ulcers cause difficulties with maintaining nutrition. The most serious complication of monkeypox is the corneal infection. Ocular infection may result in corneal scarring and permanent vision loss. The majority of the complications associated with the monkeypox infection are detected in unvaccinated individuals than vaccinated individuals. Since the eradication of smallpox, the routine vaccine is no longer provided to today's popular due to cross immunity. Individuals that had been vaccinated against smallpox prior to the 1970s are much less likely to be developing the complications associated with the monkeypox virus infection. Sepsis, septic shock may also occur, and this is largely due to the overly exaggerated immune responses. Monkeypox is a self limiting viral illness, and due to the nature of illness, lifelong complications are very rarely noted. Currently, there are no specific treatment for monkeypox disease. However, experience with smallpox suggests that the vaccinia vaccine, cidofovir, tacovir treatment, and vaccinia immunoglobulin IVG have may have a use in monkeypox treatment. As per the World Health Organization, tecto- tecovirimat TECOVIRIMAT was developed for smallpox and was licensed by the European Medicines Agency EMA for the monkeypox in 2022. Currently, it is not yet widely available, and as such, any use of tecovirimat should be monitored. Cidofovir has antiviral activity against variety of viruses by inhibiting viral DNA polymerase. Tecovirimat has been found to have specific efficacy on several orthopox virus, including variola, vaccinia, cowpox, ectoromella, rabbit pox, and monkeypox. Tecovirimat is the oral intracellular viral release inhibitor with the potential therapeutic effects on monkeypox. Despite the suggested treatment inventions, supportive and symptomatic therapy has been deemed the basis of managing a monkeypox viral infection. It is important to understand that besides symptomatic management and prevention complications, there is no clear treatment for monkeypox. With the 2003 US outbreak of monkeypox and the current presentation of monkeypox cases internationally, more research must be conducted before any treatment for vaccine can be considered. The overall goal of laboratory testing in this context is enable timely and accurate confirmation of the infection to support the breaking of chains of transmission to stop the outbreak. And any individual that meets the suspected case definition of monkeypox should be offered testing in appropriately equipped laboratories by staff trained in the relevant technical and safety procedures. Confirmation of monkeypox virus infection is based on nucleic acid amplification test NAAT using real time or conventional polymerase chain reaction PCR for detection of unique sequences of viral DNA. PCR can be used alone or in combination with sequencing. The recommended specimen type for laboratory confirmation for monkeypox is skin lesion material, including swabs of lesion surface or exudate, roofs from more than one lesion or lesion crust. It is recommended that all manipulations of specimens organ or originating from suspected probe or confirmed cases of monkeypox in the laboratory may be conducted according to the risk-based approach. All test results, positive or negative, should be immediately reported to the national authorities, and member states are requested to immediately notify WHO under the International Health Regulations, that is IHR 2005, of positive laboratory results, including laboratory tests that awaits confirmation. Please like, subscribe and comment. Thank you.